Welcome to the Deep Dive. We're your shortcut to understanding some pretty complex stuff. Today, we're jumping into a topic that honestly affects so many of us: anxiety, obsessions, and compulsions. We're basically unpacking a key chapter from Psychopathology and Mental Distress to make it really clear and useful, especially if you're studying mental health or just curious. Our goal is to walk you through the big ideas, theories, diagnosis, what it all means without getting lost in the jargon. So first things first, let's get some terms straight. What's the difference between anxiety and fear? Anxiety. Think of it as that background hum of unease, tension, worry, maybe your heart races a bit, but it's often kind of vague, not tied to one specific thing right now. It's more about what might happen.
Exactly. Whereas fear is that immediate jolt. It's your brain's alarm system going off in response to a specific danger you see right in front of you, like slamming on the brakes to avoid a crash. It's intense, automatic, but usually pretty brief.
Okay, so anxiety is future-focused worry. Fear is present-focused danger
Right.
response. Got it. And then obsessions versus compulsions.
Simple way to think about it. Obsessions are the thoughts. Compulsions are the actions.
Ah, okay.
Obsessions are those unwanted, sticky thoughts, images, maybe urges that just loop in your head and are really hard to ignore.
Right.
And compulsions are the things you feel you have to do, often to try and neutralize the obsession or prevent something dreadful from happening.
To make this less abstract, we'll be talking about the Steadman family today. Their experiences really highlight these different facets. There's Teresa, she's 35, dealing with this sort of constant, low-level daily anxiety, plus a new fear of public speaking. Then her daughter, Tammy, who's 8, gets really distressed when her parents leave. Lots of worry, sometimes can't even go to school.
Yeah, separation issues.
And Gary, 36, he's got these daily rituals, checking the stove over and over, the alarm, washing his hands excessively because he's worried about dirt. It makes him late a lot.
Gary's story really points towards the obsessive-compulsive side of things. And what's crucial, like you said earlier, is that everyone feels anxious sometimes or has a weird thought pop into their head.
Sure.
But it's when it becomes intense, persistent, and really starts interfering with life. That's when we look at it differently. Anxiety disorders are surprisingly common. Lifetime prevalence is over 30%.
Wow.
So the big question is always, when does normal worry cross the line into something, well, clinically significant?
1 in 3 people, that's a lot. So how do clinicians actually start to categorize these experiences? How do they help someone like Teresa or Tammy or Gary? What's the roadmap?
Right. The roadmap usually starts with the diagnostic manuals, mainly the DSM, the Diagnostic and Statistical Manual of Mental Disorders, and the ICD, the International Classification of Diseases. Let's maybe touch on a few key anxiety disorders first.
Okay.
So specific phobia, this is probably the one most people think of. An intense, really out of proportion fear of a specific thing: spiders, heights, flying, needles, you name it.
Leads to avoiding it at all costs.
Absolutely. Avoidance is key. It tends to be more common in women and often shows up alongside other anxiety issues. Then social anxiety disorder. This used to be called social phobia. It's a deep fear of social situations where you might feel watched, judged, or humiliated.
Like Teresa's new public speaking fear.
Exactly. It's that fear of scrutiny. Meeting new people, eating in public, giving presentations, all potential triggers.
Makes sense.
Panic disorder. This one's about recurrent, unexpected panic attacks. These aren't just feeling very anxious. They're sudden waves of intense fear with really strong physical symptoms. Heart pounding, can't breathe, dizzy, feeling detached like you're dying or losing control.
That sounds terrifying.
It is. And the key for the disorder is that the attacks are unexpected and the person develops a persistent worry about having more attacks. Just one panic attack doesn't mean you have panic disorder.
Right. It's the pattern and the fear of the fear.
Precisely. And linked to that is agoraphobia, literally fear of the marketplace. It's the fear of being in places or situations where escape might be difficult or help unavailable if you did have panic-like symptoms.
So like public transport, crowds, being far from home alone.
Yeah, those kinds of situations. It often goes hand in hand with panic disorder, but not always.
Okay. And Teresa's general everyday anxiety.
That sounds a lot like generalized anxiety disorder, or GAD. This is excessive worry, but it's global, not focused on one specific fear, like a phobia. People with GAD worry about lots of different things: health, money, work, family, and find it really hard to control the worry.
Just constant unease.
Yeah, and it comes with physical symptoms too. Restlessness, easily fatigued, muscle tension, sleep problems, trouble concentrating. You mentioned COVID earlier. GAD rates really jumped then. Big societal stressors can definitely amplify this kind of widespread worry.
That makes sense. And little Tammy.
Her distress points toward separation anxiety disorder. Mostly seen in kids, it's an excessive fear or anxiety about being separated from people they were attached to, usually parents, worrying something bad will happen to them, refusing to go to school. That fits Cammie's picture.
Okay, so that covers a lot of the anxiety side. But Gary's checking, his hand washing, where does that fit?
That brings us squarely into obsessive-compulsive disorder, or OCD. It's defined by having obsessions, compulsions, or usually both, and they take up a lot of time and cause significant distress.
So Gary's thoughts about the stove being left on, that's the obsession.
Exactly. That persistent, intrusive worry. And the repeated checking, the ritualistic behavior, that's the compulsion. He feels driven to do it to reduce the anxiety the thought causes. Same with his fear of dirt and the excessive hand washing.
Obsession, thought, compulsion, action. Got it.
And OCD is actually part of a broader category now in the DSM and ICD called obsessive-compulsive and related disorders. This includes things like body dysmorphic disorder, BDD, being preoccupied with perceived flaws in appearance, and hoarding disorder, the difficulty discarding possessions.
Okay, so we have these neat boxes, these labels, but you mentioned complications earlier. It's not always straightforward, is it?
Not at all. And this is where things get, well, debated. A huge issue is comorbidity. The fact that these disorders often occur together. Someone with OCD might also have GAD and depression. In fact, something like 90% of people with OCD have at least one other disorder.
Wow, 90%.
Yeah, so it makes you ask, are these truly separate things? Or are they maybe different expressions of some underlying vulnerability? Are we slicing the pie too thinly?
Are the categories themselves the problem?
That's the question some alternative models are asking. For example, the Psychodynamic Diagnostic Manual, PDM-2, focuses less on symptom checklists and more on the person's subjective experience of anxiety, linking it to deeper, maybe unconscious, fears about loss, self-worth, things like that.
More about the why behind the feeling.
Kind of, yeah. Then you have models like HiTOP, the hierarchical taxonomy of psychopathology. It tries to solve the comorbidity problem by organizing symptoms into broader dimensions. So instead of separate boxes for GAD, social anxiety, depression, they might all fall under a larger internalizing umbrella. It's more about spectra than distinct categories.
A bit more fluid.
Exactly.
Yeah.
And then there's the power threat meaning framework, PTMF, which is quite radical. It fundamentally challenges the idea of pathologizing these experiences at all.
How so?
It suggests that what we call symptoms are often understandable, even adaptive responses to real-world threats like poverty, discrimination, trauma, or difficult relationships. So maybe Tammy's separation anxiety isn't a disorder in her, but a meaningful response to something threatening in her environment, like bullying at school, maybe.
So it reframes it as survival, not sickness.
In a way, yes.
Okay.
It pushes us to look at the context, the power dynamics, and the meaning the person makes of their experiences, rather than just labeling the distress.
That's a really different lens. It makes you think about how our understanding has shifted over time. Where did our current ideas even come from?
It's been a long road. Way back, ancient Greece through the Renaissance, anxiety wasn't really seen as its own thing. It got lumped in with melancholia, and explanations often involved imbalances in bodily humors or even spiritual issues like fear of damnation.
Not very scientific.
Not by today's standards. Then, from the 18th century onwards, things started shifting. Anxiety got gradually separated from just sadness and linked more to nervous disorders. The medical model started taking hold.
People started describing these things more clinically.
Yes, in the 19th century, you see early descriptions that sound familiar. Westphal coined agoraphobia and started distinguishing obsessions from delusions. Esquirol described patients with OCD-like symptoms. Hartenberg wrote about social anxiety.
So the concepts were emerging.
They were. But the big split, the real formal separation of anxiety disorders from depression into distinct categories we use now, that largely happened with DSM-3 in 1980. It aimed for reliability, clear criteria for diagnosis, but, as we discussed, whether that sharp cleavage between anxiety and depression was entirely wise is still debated, given how often they overlap.
Okay, so we've gone from humors to diagnostic manuals. Let's switch gears now to the biology. What's actually going on inside our brains and bodies?
All right, the biological perspective is huge. Let's start with brain chemistry. For anxiety, remember those older drugs, benzodiazepines? Like Valium, Xanax, Klonopin?
Yeah, anxiolytics.
They work by boosting GABA, which is the brain's main inhibitory neurotransmitter. Basically, it tells neurons to slow down, calming the system. They can be effective for short-term, intense anxiety.
But they have issues, right? Addiction potential.
Exactly. They can be habit-forming, cause drowsiness, memory problems, and rebound anxiety when stopped. So they're used much more cautiously now, mainly for short periods.
So what's used instead?
Interestingly, antidepressants, especially SSRIs, selective serotonin reuptake inhibitors, are now the first-line treatment for most anxiety disorders.
Wait, antidepressants for anxiety?
Yep. It surprised people initially, but it turns out that neurotransmitters like serotonin and norepinephrine are heavily involved in both mood and anxiety regulation. So boosting serotonin with an SSRI often helps with anxiety too.
Like Teresa getting Paxil or Tammy getting Prozac, both SSRIs?
Exactly. Though it's important to note, SSRIs can have side effects too, and there are warnings about potential risks, especially when prescribing them to children and adolescents.
Okay. What about for OCD?
SSRIs are also the main medication for OCD. They boost serotonin. Gary's experience trying different ones. Zoloft, Prozac, Luvox is pretty typical.
Does it work the same way as for anxiety or depression?
Often, OCD requires higher doses of SSRIs, and it can take longer to see effects, maybe 8 to 12 weeks. And even then, a significant number of people don't get full relief from SSRIs alone. They usually work best alongside therapy, like CBT. And stopping the medication often leads to relapse. Sometimes other drugs are added to augment the SSRI effect, but that comes with its own set of risks and benefits.
Beyond neurotransmitters, what about the brain's plumbing, the structures involved?
Good question. For anxiety and fear, key areas that light up are the amygdala. Think of it as the threat detection center, involved in emotional memory, and the insula, which processes internal body states and social emotions. The idea is that in anxiety disorders, these areas might be overly reactive.
Hair trigger alarm system.
Sort of, yeah. For OCD, the focus is often on a specific brain circuit, the cortico-striatal-thalamo-cortical loop. It connects areas involved in decision-making, error detection, and habit formation. The theory is that dysfunction in this loop leads to those stuck thoughts and repetitive behaviors. It's like the brain can't properly signal that a task is complete or a threat has passed.
And what about genes? Does it run in families?
Definitely. There's a clear genetic component. Anxiety disorders and OCD cluster in families. Twin studies show moderate heritability, meaning genetics explains a chunk, maybe 20–60% of the variation we see.
But it's not just one anxiety gene or OCD gene?
No, absolutely not. It's polygenic. Many genes are involved, each contributing a tiny amount to the risk. And critically, it's about gene-environment interaction. Having a genetic predisposition doesn't guarantee you'll develop the disorder. Life experiences, stress, and other environmental factors play a huge role in triggering it.
Okay, genes, brain circuits. What about the bigger picture, like evolution?
Evolutionary perspectives argue that basic fear and anxiety responses are adaptive. They helped our ancestors survive real threats.
Fight or flight.
Right. The problem arises when these evolved defense mechanisms go into overdrive or misfire in modern environments. Maybe we're prepared by evolution to fear snakes or heights more easily than, say, cars, even though cars are statistically more dangerous now. Or perhaps GAD is an overactive danger avoidance system. Or OCD checking behaviors are a malfunctioning mechanism originally useful for group survival, ensuring safety, cleanliness, etc. It's intriguing, but also hard to prove definitively.
And you mentioned the immune system and gut. How do they fit in?
Yeah, this is a really burgeoning area. There's growing evidence linking inflammation in the body, inflammatory markers, altered stress hormone levels like cortisol to both anxiety and OCD. Yeah. And related to that is the gut-brain axis. We have trillions of bacteria in our gut, the microbiome, and they communicate biochemically with our brain. Imbalances in these gut bacteria are increasingly suspected to play a role in anxiety, depression, and maybe even OCD.
So gut feelings might be more literal than we thought.
Could be. Highlights how interconnected everything is: brain, body, immune system, even our gut microbes.
It's amazing how intricate the biological side is, but clearly it's not the whole picture, right? What about the psychological angle?
Absolutely critical. Biology provides the hardware, maybe, but psychology looks at the software, our thoughts, feelings, learned behaviors, and past experiences. Let's start with the psychodynamic perspective.
Okay, Freud and beyond.
Pretty much. Classic psychoanalysis, like Freud's case of little Hans fearing horses, linked phobias to unconscious conflicts, like unresolved feelings about parents, displaced onto something else. Modern psychodynamic views are less focused on those specific complexes, but still emphasize how unresolved unconscious conflicts, Or maybe difficult early relationships, like insecure attachments with parents, can create underlying vulnerabilities that manifest as anxiety later on.
So maybe Gary's OCD isn't just a brain circuit issue, but linked to deep-seated self-doubt stemming from his upbringing.
That's the kind of connection a psychodynamic therapist might explore, yes. How early experiences shape our core sense of self and our ways of coping with distress.
Okay, what about the behavioral side? How we learn anxiety?
This is core cognitive behavioral therapy, CBT, territory. Behaviorism highlights conditioning. Classical conditioning explains how we might learn to fear something neutral if it gets paired with something genuinely scary, like Watson's little Albert experiment with the rat and the loud noise.
Right.
Operant conditioning explains how anxiety is maintained. If avoiding something reduces your anxiety, negative reinforcement, you're more likely to keep avoiding it, even if it limits your life.
The avoidance trap.
Exactly. And social learning means we can also learn anxiety by watching others. If Cammie sees Gary getting really anxious when her mom doesn't answer the phone, she might learn that that's something to be very worried about.
And in CBT, the cognitive part, our thoughts.
Crucial. Cognitive theories, pioneered by people like Aaron Beck, focus on how our thinking patterns contribute to anxiety. It's often about faulty appraisals, overestimating threats, underestimating our ability to cope.
Seeing danger everywhere.
Right. For panic attacks, the catastrophic misinterpretation model is key. Someone feels a normal bodily sensation, heart flutter, slight dizziness, and immediately jumps to the worst conclusion, I'm having a heart attack or I'm going crazy. That interpretation fuels the panic.
That thought spiral.
Precisely. And for OCD, cognitive models suggest that while everyone has occasional weird or intrusive thoughts, people with OCD give them too much importance. They might feel overly responsible for preventing harm, or engage in thought-action fusion, believing that thinking something bad is almost as bad as doing it.
Like Gary thinking, if I don't check the stove again and the house burns down, it's my fault.
Exactly that kind of thinking. It drives the compulsion to check, to neutralize the thought and the perceived responsibility.
So if thoughts and behaviors are driving this, how does CBT intervene? What do the therapies actually do?
A cornerstone, especially for phobias and OCD, is exposure plus response prevention, often called ERP.
Exposure. Sounds scary.
It can be, but it's done carefully and gradually. The exposure part means confronting the feared situation or thought directly. The response prevention part means resisting the urge to perform the compulsion or escape the situation.
So for Gary, it might mean touching something dirty and then not washing his hands immediately.
Exactly. Or purposefully leaving the house without checking the stove multiple times. The idea you learn through experience that your feared outcome doesn't happen, or that you can tolerate the anxiety, and it eventually decreases. It basically breaks the avoidance cycle.
Okay, what about things like Teresa's public speaking fear?
For that, systematic desensitization is common. It's more gradual. You create a fear hierarchy, starting with something mildly anxiety-provoking, like thinking about giving a speech, and slowly work your way up to the real thing, practicing relaxation techniques along the way.
Baby steps.
Pretty much. Other techniques include modeling, watching the therapist do the feared thing, using virtual reality for exposure, cognitive restructuring, challenging those faulty thoughts directly, and thought stopping, though that's debated now compared to acceptance approaches.
Acceptance.
Yes. Newer waves of CBT, like mindfulness-based cognitive therapy, MBCT, and acceptance and commitment therapy, ACT, focus less on changing thoughts and more on changing your relationship to them. Learning to observe difficult thoughts and feelings without judgment, accepting their presence without letting them dictate your actions.
So notice the anxious thought, acknowledge it, but don't get swept away by it.
That's the core idea. Overall, CBT, particularly exposure therapies, is generally considered very effective, often the first-line psychological treatment, especially for OCD. But it's not a magic bullet. Remission rates hover around 50%, so there's still room for improvement.
And Tiffany Donhaus's story you mentioned, the spoken word artist with OCD, that really drove home the personal side.
It really did. Her journey highlights that combination, needing medication for severe symptoms, finding it crucial, but also needing to find her own psychological path, her own meaning-making through art and performance, to truly conquer it. It wasn't just ERP, it was transforming her pain. It shows how individual the recovery journey can be.
What about other psychological approaches, beyond psychodynamic and CBT?
We should definitely mention the humanistic and existential perspectives. Person-centered therapy from Carl Rogers sees anxiety arising from incongruence, a gap between your true self and the self you feel you have to be to get approval. Therapy provides empathy and unconditional positive regard to help bridge that gap.
Creating a safe space to be authentic.
Exactly. And existential perspectives view anxiety as partly a fundamental aspect of being human, facing the givens of existence like death, freedom, isolation, meaninglessness. Normal existential anxiety can motivate us. Neurotic anxiety arises when we avoid facing these realities, getting caught up in trivialities instead.
So maybe Gary's obsessive checking is a way to avoid confronting bigger life questions, like his unfulfilled dream of writing.
That's a possible existential interpretation, yes. Therapies like logotherapy focus on finding meaning. And emotion-focused therapy, EFT, helps people process painful past emotional experiences that might underlie current anxiety, like shame from past bullying contributing to social anxiety. EFT is showing good promise, sometimes comparable to CBT for anxiety.
Okay, so we have biology, individual psychology, but we don't exist in a vacuum, right?
Mhm.
What about the wider world, culture, society relationships?
Absolutely crucial. The sociocultural perspective adds vital layers. We see clear cultural differences in how anxiety is expressed. In some Asian cultures, dizziness might be a primary complaint. In Japan, there's taijin kyofusho, that social anxiety focused on offending others. In non-Western cultures generally, anxiety often manifests more physically somatic symptoms rather than explicit worry.
So the feeling might be universal, but the language for it differs.
And maybe even the experience itself is shaped by cultural norms. Think about the debate around COVID-19 anxiety syndrome. Was it a new disorder or a perfectly understandable reaction to a global threat, maybe medicalized unnecessarily? Context matters.
And things like poverty.
Economic conditions definitely play a role. Lower socioeconomic status is linked to higher reported anxiety symptoms. Yet, interestingly, the actual prevalence of diagnosed anxiety disorders is often higher in wealthier countries.
That seems contradictory.
It's complex. Maybe there's less stigma or better detection in richer countries, or perhaps in situations of real ongoing hardship, anxiety feels, well, warranted. Less like a disorder and more like a realistic response to circumstance.
And gender. You mentioned women are diagnosed more often.
Yes, roughly twice as often for most anxiety disorders, and they receive far more prescriptions for anti-anxiety meds and antidepressants. Now, are there biological differences? Possibly. But feminist critiques powerfully argue that we also need to look at social factors, higher rates of trauma, abuse, discrimination, societal pressures. Is women's understandable distress being overly medicalized instead of addressing the root societal issues?
That's a really important point.
And the service user perspective highlights the impact of stigma. Being diagnosed with anxiety or OCD is often still seen, unfairly, as a sign of personal weakness. This internalized stigma can really hinder recovery and stop people from seeking help in the first place.
Makes it even harder to cope.
Definitely. Finally, systems perspectives look at the immediate social environment, especially the family.
How the family dynamic affects things.
Exactly. Concepts like expressed emotion, e.e., high levels of criticism, hostility, or over-involvement from family members are linked to poorer treatment outcomes. If Teresa is constantly critical of Gary's checking, it might make things worse, not better.
Creates more stress.
Right. And accommodation where family members try to help by doing the compulsions for the person or helping them avoid feared situations actually reinforces the problem long term. Like Tammy's parents letting her skip school, or Teresa checking the stove for Gary. It seems helpful, but it prevents them from learning to cope.
Undermines therapy, maybe.
It can, yes. So family therapy often aims to change these dynamics, reduce EE, stop accommodation, and improve communication and boundaries within the family system.
Okay, wow. We've covered biology, psychology, society. How do we pull all these threads together? Is there a way to integrate all this?
That's the million-dollar question. Neuroscientist Joseph LeDoux offers a really insightful perspective here. He argues that while our brains have sophisticated threat detection circuits like the amygdala, the subjective feelings of anxiety and fear are uniquely human constructs.
Meaning?
Meaning, the brain circuitry might fire in response to a potential threat, but the feeling we label anxiety or fear only arises when our conscious human mind interprets that physiological data and the situation. Other animals have threat responses, but they don't reflect on them and worry about worrying in the way we do.
So the feeling isn't just the brain activity itself.
No, it emerges from our interpretation of it. And LeDoux says this is why psychiatric drugs, which target the underlying circuitry, can help manage the physiological arousal, but often can't eliminate the feeling of anxiety entirely, because that requires addressing the interpretative layer too.
Which points to the need for talk therapy.
Exactly. It really emphasizes why we need an integrative approach.
Hmm.
You'd have to consider the biological predispositions, the psychological learning and thought patterns, and the sociocultural context to truly understand and help someone experiencing anxiety or OCD. No single perspective holds all the answers.
That makes so much sense. It really brings it all together. So just to quickly recap, we've looked at the key differences between anxiety and fear, obsessions and compulsions. We've walked through the main diagnostic categories from the DSM and ICD, but also touched on alternative ways of thinking, like HiTOP and the PTMF. We saw how understanding evolved historically. We dove deep into the biology, brain chemistry, structure, genetics, evolution, even the immune system and gut. Then we explored psychological angles, psychodynamic conflicts, CBT's focus on thoughts and behaviors, humanistic ideas about congruence, and the importance of acceptance. And finally, the crucial role of sociocultural factors, culture, economics, gender, stigma, and family dynamics. Phew. It's clear we need all these pieces for the full picture. Which leads me to a final thought. Given how much our understanding has changed already, I mean, from humors to neurotransmitters, from demons to defense mechanisms to faulty cognitions, what might future generations think of our current understanding? Where might our blind spots be today? Something to ponder. Thank you so much for joining us on this deep dive into anxiety, obsessions, and compulsions. We really hope it's given you a clearer picture, maybe sparked some new questions, and helped you connect the dots in your own learning.
Absolutely. Keep exploring. Stay curious. It's a complex field, but understanding these experiences better helps us all.